advanced care planning is an act of love. I believe advanced care planning is a process. But if you have a serious illness, it is essential that you have conversations with your family and your caregivers and your clinicians about what these things actually mean for you and what your goals are and what's important. What empowered care looks like, saying, hey, even if you're not comfortable talking to me about it, I want to talk to you about it. And here's how I want to engage. I maybe want to know everything you know, or maybe I don't need all the information. Here's what I'd like to know so that I can be an informed decision maker.
Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancering Show. Hi, everyone. Welcome back to The Cancering Show. I am super excited about our guest today and our topic. We have not talked enough about palliative care and the difference between that and hospice care. Palliative care is specialized medical care for anyone with a serious illness that can include pain, but also includes symptoms of that disease and can include treatment of that disease as well as treatment and symptom management. So we want to talk more about that and how that fits into total cancer care with a goal to improve quality of life for both the patient and for the family. So today, in order to further educate ourselves, we are talking with Stephanie Broussard. She is a licensed clinical social worker, supervisor, and director of social work and palliative care at Texas Oncology. She has spent her career providing direct patient care as well as developing programming to increase access to care for the seriously ill in the home, the community, and in clinical settings. She's a Louisiana native who moved to Texas in 2005. Stephanie, welcome to The Cancering Show.
Thank you so much for having me.
So, Stephanie, we wanted you to come and talk to us after I heard you speak at the recent Survivor Conference in New York City. And I just was amazed at the way that you spoke about palliative care and supportive care in a way that was so down to earth and so approachable. And I really felt like our listeners could learn so much from you. It's so important to have these conversations. And yet, as providers, as caregivers, as a community of patients, we know it's not easy. So first, can you take us through these terms that we're talking about? Talk to us about what is palliative care?
Great. Actually, it's my favorite question because I think there's so much misinformation around what palliative care really is. And so how I break it down is palliative care is really the comprehensive approach to addressing total pain, meaning it is an interdisciplinary approach to addressing the emotional pain, the physical pain, the spiritual distress of an individual living with a serious illness. And this can be provided by physicians, nurse practitioners, social workers, a chaplain or a spiritual counselor, as they're often called, to really address every element of care. So taking care of that whole person to alleviate the suffering or distress that comes when you have a serious illness. And a lot of people get confused when they hear palliative care because we also think about hospice, because hospice is a type of palliative care. And so people will hear the term palliative care and automatically think end of life, whereas palliative care is appropriate for anyone at any stage, at any age, living with a serious illness.
I love that. It's so amazing. And you specifically started with pain, but we know supportive oncology takes care of a lot of symptoms. For you and your patients, what are the main symptoms you are helping patients with and through?
So for me specifically, of course, because I'm a social worker, I'm a clinical social worker, I address the emotional suffering, the psychosocial emotional needs of patients, meaning that depression, anxiety, the exponential crisis to some degree, but it also can be addressed by the spiritual counselor. But really looking at how do we alleviate the emotional burden, the emotional suffering that comes with a serious illness, because we know that that can also manifest into physical pain. And so we also can address physical pain through helping to do skills like mindfulness and meditation and different things to help learn to cope. And we teach coping skills as well. So we really address the comprehensive suffering of patients, but with our own modalities and own approaches. So it's right alongside the physician that may be addressing physical pain through pharmacological interventions or medication interventions.
Mm-hmm. And you work with the seriously ill patient all the time. Tell us when a patient or a family would choose palliative care as part of their treatment.
So when people usually choose it, it's probably too late. So when I would like for them to choose it is when we're diagnosed. I believe that every patient that is diagnosed with a serious illness would benefit from access to palliative care. I think what happens is that sometimes we're not exposed to palliative care until we're seeing evidence of a symptom burden. But I believe that if we engage palliative care early enough, then how we have symptom burdens is less likely. We're better equipped. We're not behind the 8 ball trying to catch up and figure out how to manage something that already exists. When we know that there's some diagnoses that just have a heavy symptom burden, and if we can get in front of it, then patients do better. And even the medical team does better in trying to address what we need.
Yeah, I love that you said that, both the patients and the medical team. And we've been talking a lot about caregivers. I think the caregivers certainly do better as well when you get this whole person approach. So when in your clinical team's process, do you as the social worker get involved? Do you get involved right at the initial referral to the palliative care team, or do they only bring you in if the doctor senses that your specific skill set is needed?
So it can vary. So one thing I do want to acknowledge is what you said about the caregiver. One of the unique things about palliative care is that it's one of the only specialties that also provides services to the family and caregiver, meaning that part of how we care for the patient is understanding that we have to care for the person that cares for the patient too.
So true.
And so we provide, whether it's therapeutic services, supportive services to them as well. So I did want to acknowledge that. But for example, at my current employer, it's a little more reactive, right? If there's an assessment of need, then the social worker is brought in to provide assistance because we don't have as many of a comprehensive approach to palliative care as we would like to, just due to the need and bandwidth.
Yeah.
In regards to ideally in palliative care, what we would want to see is that just as soon as any member of the team touches the patient, every member of the team touches the patient, because it's a comprehensive approach to palliative care. We believe that comprehensive supportive palliative care is interdisciplinary, meaning that you can't treat one element without treating the other. So even if a symptom burden isn't present, we want to proactively assess and provide skills and means to address those things so that a crisis doesn't emerge. In my private practice, when I was seeing patients, of course, my job these days is pretty big and I'm in school too, so I'm not seeing as many patients in private practice, but I will receive referrals from people, physicians or members of community would send referrals for patients who are having new diagnoses and needing to process the diagnosis, or families coping with adjusting to a new diagnosis. So I would see them from the start, or almost sometimes patients who are having difficulty adjusting and processing mortality. And so maybe they're closer to end of life and thinking about transitions and legacy making and meaning making. And so that would be the focus of that work. And so I would see patients along the continuum, even in my private practice at my job. It could be across the continuum of care because we know that addressing that emotional distress could be at any level or stage of care.
Yeah. And you said, as clinical teams, we're so busy dealing with treatment or, looking further down the road that sometimes we miss that opportunity to refer to palliative care early on. So what would you say to a patient, family, or caregiver that really wanted to, seek palliative care in their treatment location? Where should they go? Who should they talk to? Or how do they ask for it?
I think that first conversation should be with your primary provider. And you can say, I've heard about this thing called palliative care. Do you think I'm a good fit for it? Or where can I access it? The reality is that palliative care, even as a specialty that we know is completely important and valuable, not all patients have access to palliative care because there's still some barriers. And so there may be limitations. Your practice may not have an actual palliative care team in your practice. That doesn't mean you can't get access to palliative care. There are a lot of different modalities where some of them are clinic-based. Some of them, they even have some home programs that are available. Your payer, your insurance may even have a type of palliative care model that's available as well. Some of the programs are usually geared towards specific needs. So you may not get a complete comprehensive approach to palliative care if that's not available in your location. However, asking is the first step so that you know what you have access to. And then your provider is aware that my patient wants this. How do I make sure that they get access? My hope would be that if you don't have access at your primary site of service, that your physician is able to palliate you as well. And what I mean by that is that there are actually not enough palliative care providers for every cancer site of service or every cardiology or pulmonology or even hospital system to have a palliative medicine physician and have a comprehensive palliative care team. So what we hope is that your medical professionals have been trained in some level of palliation to address those needs when there are gaps and when we don't have access to palliative care. If I had my way, every patient everywhere would have access to palliative care. I have a sign in my office that says palliate them all, but we're not there yet. Yeah. And so we hope that when you don't have access to palliative care, your physicians know, oh, they want these extra layer, they need this. So let's make sure that this is something that we're adequately addressing.
Yeah. And Stephanie, tell me, I know that every doctor has not only been exposed, but has received some training and how to palliate symptoms. We all know how to treat nausea, how to treat pain, how to deal with the emotional symptom burden associated with disease, even how to treat shortness of breath. We know how to manage these symptoms, but often do it in a clinical way. Do you feel like every social worker has some exposure or experience with palliative care? Or when people are trying to kind of put together their own palliative care team, are there certain things they should look for in a clinical social worker? Or if they don't have access to that, where else should they go?
Absolutely. So I believe that there are specific skills. It is a little different. The scope of social work is so vast and broad that not all social workers are created equally. As much as I love the discipline of social work, and I will always be a champion, I believe the scope is underutilized. And so a lot of times people don't know what all we're able to do. Like when I talk about social workers treating pain, people are like, well, how can you do that? And so people don't really understand the vast nature of the scope. However, in order to be able to maximize the scope, it does require some additional training and skills. And so if you're looking for a social worker that is equipped, first of all, I believe that there are two different types of palliative social workers. The first is where we would see an LMSW, where it's providing more of those navigation type interventions for palliative care. Think like case management, where we're looking at what is the psychosocial needs, how do we address those, and they're providing more of that short-term interventions related to the emotional needs of patients.
Right.
When I think about the more comprehensive scope of a clinical social worker, like an advanced certified palliative and hospice social worker, those skill sets are going to be clinical in nature, where they are also able to look at assessing for mental health or behavioral health needs in addition to the symptom burden, and treating those things comprehensively through their assessment and skill set and providing therapeutic interventions to address those. LMSWs can also do that to some degree, but they require training to do that. Even an LCSW who's a great therapist does not mean they're a great palliative care therapist. Okay. Or doesn't mean they're equipped with the skills necessary to provide palliative care interventions. They can be trained to do so, and they can be equipped with exposure to situations that allow them to do that. But I do believe it requires additional training and scope.
Okay. Now let's move on to end-of-life care. How is that different than palliative care? Walk us through the choices there.
Okay, so when we think about more common, of course, hospice is what people hear when we think about end-of-life care specifically. And so it's important for us to know that hospice as defined is really a Medicare benefit, and it's a service. And so oftentimes people think hospice is a place, and it actually isn't. Hospice is a type of palliative care, meaning that it is a type of care that addresses total pain and the symptom burden that comes with end of life, a terminal disease. So for a person to qualify for hospice, they have to have what is perceived to be a terminal diagnosis of 6 months or less. Now, there are people who live past that 6 months, and if they're on hospice and continue to meet the criteria for that diagnosis, then they get to stay on hospice. There are even people who graduate from hospice because they have not continued to decline, but benefited from the symptom management and support provided by hospice services.
Yeah.
But in order for a person to meet criteria for hospice, they have to have a terminal diagnosis.
Right. Well, I always, when we're talking about whether or not to do hospice with a patient and their family, I always talk about one of my patients. It was in the middle of the COVID pandemic. She had a terminal cancer diagnosis, was on a treatment that could prolong her life, but she was declining rapidly from acute COVID. And in that situation, in order to be with her family, she opted for home hospice care and left the hospital on home hospice. And she walked back into my office 4 months later, looking fantastic, ready for treatment again. And just like you said, her decline did not continue. She recovered from COVID and went on to do well from the treatments we had given her before. And so she graduated from hospice and was on treatment for 3 additional years after that.
Yeah. I think sometimes we don't talk about end of life enough. I have this phrase, actually, it's one of the titles of chapters in my dissertation, but everybody's dying and no one wants to talk about it. The reality is that the moment we are born, we are dying. Unfortunately, for some people, we may know what is their life limiting disease. But if we were to have conversations about quality of life and what we want those things to look like, I think we would be more open to talking about end of life and hospice care. What hospice does exceptionally well is focus on quality of life as you define it, meaning that it is completely person-centered. It allows you to say what I want to focus on. So maybe, I'm okay with a little pain if I can stay more alert. Or actually, I don't want to feel any kind of pain. So I really want this to be eliminated. Or I want to be present with this family and I want to be here. It really allows us to dictate some things in a situation where we ultimately have no control over the time frame. And so I think when we talk about hospice with patients, it should really be focused on what's your goal? I think we hear end of life and we think about days on a calendar or time on a clock. And when I talk to patients, what I really hear from them saying is that they want more time to do what it is they want to do. And sometimes hospice is that answer because it allows them to not be in a hospital setting pursuing that. It allows them to be around family doing what they want to do on their terms. And oftentimes, I believe it's inserted into the conversation too late, and we take that opportunity for people to live on their terms while they still can.
Right.
And even if we're dying, that's still part of living.
Yeah.
And I think if we shift the narrative a little bit, we have a different perspective of what hospice can really bring and the value it can bring to families. It takes care of families. It takes care of the individual. There's even respite built in. There's even bereavement services built in. People don't know that medications are covered or even incontinence supplies. And in some situations, even nutrition when a person has a feeding tube. So there's a lot of additional services and resources that are available with hospice that people often don't get to partake in because we're scared to talk about it or scared of the word.
Right. And I think your point is so well taken. Bringing in palliative care early on allows us to talk about those goals early on. One of the things that I talk about with patients is like, I want you to know that this cancer is not curable, not to scare you and not to take away your hope, because I want you to know that this time is valuable. And that means you get to dictate. You get to decide if you're going to take chemo this week or go on a cruise. You get to decide if you want to do that here or with family that lives in another state, because I want you to understand that this time is valuable. Even if we're still doing treatment, still doing palliative care, because I don't want people to come to a point where we're having a conversation about hospice and they're like, but you never told me I was this close, or I would have done X, Y, and Z last year, last month, if only I had known. And so I think it's so important to have those conversations with your doctor or, with your caregivers. If you've had the conversation with the doctor, but maybe your caregivers aren't aware about that time being valuable.
I think that's so important. I think we underestimate the value of advanced care planning and goals of care conversations that include exploring somebody's values and their beliefs and what's important to them. And where there's opportunity is if we have these conversations early and often and we insert them as standard of care, then people they don't feel like, oh, my doctor's talking to me about what's important to me, so it must be time to pack up things and it's over. My doctor is giving up on me. The reality is if we engage in these conversations and we understand, even for the community, for them to understand if your physician engages you in a conversation about goals and values, it's because they want to know what's important to you and want you to be part of making decisions that line up with what's important to you for your goals or your treatment and being able to direct that care. And so I think it's so important for us to change that narrative too. Advanced care planning is necessary. It's part of you being part of your care. But also, I think just even if your provider doesn't come to you with that conversation, because there's still a lot of discomfort in talking about goals of care because we think patients may think we're not thinking they'll do well or we're trying to take their hope away.
Right.
And so if your provider doesn't talk about goals of care, it's also okay for you to engage them in the conversation. I hate to shift that burden, but I think that's what empowered care looks like, saying, hey, even if you're not comfortable talking to me about it, I want to talk to you about it. And here's how I want to engage. I maybe want to know everything or maybe I don't need all the information. Here's what I'd like to know so that I can be an informed decision maker.
Right. And as providers, I will tell you, if we're listening, if you're really paying attention, patients will tell you, even if you're not in that conversation, they'll say, well, I would never want to be X. or I would never want to do X.
Absolutely.
And is part of those treatment decisions, and to really listen to that and really pay attention and say, hey, it sounds like what you're saying is this, let's talk about it. So I totally agree. People are ready to have those conversations. Now, you mentioned advanced care planning, and that means a lot of different things to a lot of different people. I totally agree that it's about the conversation, it's about the goals, but to some people it means paperwork. Talk to us about kind of the difference between those two things, and really, if we're going to talk advanced care planning, what is the paperwork?
So I believe advanced care planning is a process. So that means that it is a process that includes having conversations about goals, values, and wishes within the context of understanding disease process. And as a result, some people may complete advanced directives, which is the paperwork. But a goals of care conversation or advanced care planning does not have to end in paperwork for it to be successful. I believe what happens in a successful advanced care planning conversation is where, number one, it's a conversation that is ongoing. It's a process,
Absolutely.
But where the patient is informed of prognostic information and is aware, but then the clinician is then informed of what is important to the patient in regards to goals and values. And then the person who would need to make decisions in the event that the patient is not able to is also equipped with decision-making ability, meaning that they not only have directives if necessary to complete those things, but also they are informed with what's important in the context of situation and decision making. So for example, when I was in acute care, I would see patients where families would be completely torn apart because we made Jimmy the medical power of attorney, but Jimmy had no idea what that loved one would have wanted. And so they're making the decisions last minute. And then families disagree about, what Jimmy would have wanted. And Jimmy would have wanted this and wanted that. When if the conversations are had in a way that also empowers the patient to have conversations with their family, number one, that reduces that burden on the bereaved family later. Mm-hmm. But then also they get the documents that they need to be able to execute those decisions and have a decision-making authority if the time were to come. Yeah. And so the paperwork looks like, I believe every human being over the age of 18 should have a medical power of attorney or a health surrogate, depending on what state you're in, documented on paper, and then a directive to physicians or a living will. And those, and in most states, a directive to physicians or a living will usually only covers two circumstances. If you're in an irreversible condition, what would you want them to do? Or if you're in a terminal condition, what would you want them to do? And that means, would you want them to use all measures available, or would you want them to allow you to have comfort care? And that's right. People, I think, for every human over the age of 18, I think that's appropriate. But if you have a serious illness, I believe it is essential that you have conversations with your family and your caregivers and your clinicians about what these things actually mean for you and what your goals are and what's important. And I tell this story all the time. Advanced care planning, I believe, is just as important as labs. We would never treat a patient without doing labs first.
I love that.
What do we look like treating patients without knowing what their goals and their values and their priorities are? That means we're doing it blind. We have no context, no clue. So that should be what we do. And I believe advanced care planning is ultimately the answer to improving access and utilization of palliative care and end-of-life services.
Right. So it, I think, busts up a lot of the myths about what it is and what it isn't.
Absolutely. Yeah. And I think people think, especially one of the things that I've seen firsthand is that we can't ignore like the historical context and the mistrust and those kind of layers that come with advanced care planning and why people are resistant, even the religious and spiritual elements of their being not aligning with sometimes the spiritual and faith elements for people who are praying for miracles and that kind of thing. Like there is some issues that we'll have to discuss. And that's why I believe good advanced care planning for clinicians equips them with the ability to say, I can understand how this may feel, like how you can hold hope, but also plan, and using ways to help insert that conversation without taking people's hope away and allow them the ability to pray for a miracle while also doing everything they need to do to be informed decision makers. And it's like insurance. You don't want to get in an accident, but you get it because you're driving a car.
Right.
And so I think it's really about making sure that people understand the importance, but that they also have providers that they can trust, that they don't feel like are doing this and will just give up on them.
Right. I couldn't agree more. I think it's such an important thing to have those conversations for people to know the truth about their disease and their information, while at the same time, of course, I think we have all seen and been part of taking care of patients who survived well outside what any physician would have expected, and certainly some cures that we did not expect to cure. And yet, as you said at the beginning, we are all dying. Nobody gets out of here alive. And so to be prepared, to have your family be prepared, to know what your wishes are. I will say for myself that, my husband, and maybe it's because I work in this, but my husband has very specific instructions and knows what to do if something were to happen to me, if I were to get hit by a bus on the way home.
Yeah, I think we tap them all too. I'm always shocked when I do a training on ACP. I always ask the clinicians in the room how many have actually done it themselves.
Yeah.
And one of the trainings that I do, I actually make the clinicians role play as the patient as themselves, not a fictional patient.
Yes.
It's like if you were this patient. And I think sometimes it helps with perspective, because the reality is that if we're not faced with the ideas of and thinking about what would I want to live, under what circumstances is quality of life for me, what gives me joy, under what circumstances would my family be equipped to care for me? Would they know what to do if I were in a condition where I can't care for myself? And I think this is a conversation everyone should have, but especially if you're in a serious illness. And I think I'm an only child, and I use it as an example in training. My mama loves her baby.
Mm-hmm.
But the reality is that if I did not have the conversation with my mother and my husband together, who my husband is my medical power of attorney, my husband, because I have a very clear perspective on quality of life, I'm sure from doing this work, that if it came to it, my mom would say my husband was trying to take me out.
Right.
She would say he's doing it for the insurance money. She would say, she would have, there's
my
no
mom
way.
would do
Whereas
the
I
same.
know my mom, if she had the ability to, she would keep me in a glass case with every device attached, even if I'm just for me physically being present.
Right. For her.
And so for me, I had to sit her down for her.
Right.
And I had to sit her down and explain that to her, because it was important that she understand, and for the sake of my family, if something were to ever happen to me, my kids are going to need their grandma present.
Right.
They're going to need a united front. So I need you to know what it looks like for me in that conversation. And it's a hard conversation, and I'm well.
Right.
So I can't imagine how difficult it is for someone facing a serious illness, but it's part of what we have to do. And I tell families all the time, I believe that advanced care planning is an act of love.
Absolutely. Keeps families together.
Absolutely. Our families will always have grief. Grief is the price we pay for love. Grief is love with nowhere for it to go, right? Grief will come. They don't have to have guilt. I believe when we don't do adequate advanced care planning, we leave families with a guilt of, should I have done more? Should I have done something else? Would they have wanted this? But if we do advanced care planning, we equip them with being able in those situations to hear our voice say, I wouldn't want to be on a feeding tube. Food means too much to me. Or here's the opportunity to be like, if I can't do this and this, they get to hear our voice say that. And they can't know every situation. That's unrealistic to think. There's no, that's not realistic to think every situation we could come up and talk about, but they'll have a general idea of what quality of life is for you. And it's hard. It's difficult to have. But I've had in my own personal life when I've been able to pull from that and say, this is exactly what they said they didn't want. So let's make another decision.
I cannot think of a better place to end. Only for today, Stephanie, your expertise is amazing, and I would love to have you back at some point. But it's such a powerful statement, and it's so true. And all of us need to have our conversations. I'm picturing the conversation. I pictured myself having the conversation with my parents about their care, but I have never pictured me having that conversation about what care I would want and how that might be a good model for them to then tell me what they would want. Thank you. Thank you so much for being here for our listeners and our caregivers. I know everybody got a lot out of today. I certainly did. So we will let you go, but thank you for taking time out of your day for us.
Thank you so much for having me. And thank you so much for making this topic a focus area. I think it's just so important and to help us change the narrative.
Absolutely. Take care.
Thank you.
I'm so happy Stephanie could join us today, and I'm so grateful for her insights about palliative care and end-of-life care and the difference between those two. I particularly love how she explained advanced care planning, that it's a process and an ongoing conversation, not just a piece of paper. And in particular, to give your family the gift of hearing what you want, hearing those words in your own voice. To all of you out there, I challenge you to do some thinking about what choices you might make and how you might have those conversations with your loved ones about your own wishes. I will tell you, my husband knows that I would not want to be around if I can't enjoy a hot cup of coffee and a hot shower, and that I would want to be cremated. and that if our children are still young, I would want to be buried in a place they could come and visit. Those are really personal choices for every single one of us, and I encourage you to think about what you would want. Until then, keep listening, keep cancering, and take care of yourself. Thanks again for listening, and don't forget to submit your questions at www.cancering.com. We're here for all of those questions, and we'll get you the answers. This show is brought to you by the University of South Alabama Mitchell Cancer Institute. MCI is a cutting-edge cancer research and patient center built to fight cancer smarter in Mobile and Baldwin County, Alabama. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment population of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com or search for us on Facebook, Twitter, and Instagram. Mitchell Cancer Institute is a member of USA Health. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.